the most therapeutic forms available to politics in the past 25 years ago was the existence of Harold Park over there, because the culture of taking the betting ring was such a great leveler for people. There was a kind of culture there that was therapeutic. So what do you mean by intervention?
As a medical student, I went for a bookmaker over there. But the social group of going was definitely invented. So Seb might want to comment on this more broadly, because one of the most important movements in mental health at the moment is so-called peer workers, like people with mental illness being interventionists themselves in an organised way. So we don't have a narrow, in any sense, medical or clinical view of intervention. So we're counting, anything which has a demonstrable effect on a particular outcome, and then the outcome which we're most interested in are participation kind of outcomes. Now, it's a really interesting issue because they're also not just individual things, they may be collective things, measuring some classical sort of public health, population health effect. We talk about interventions as well at a group level. We were just discussing with Joe about family-based interventions. I'm really proud of the fact that a private philanthropist has partnered with Sydney University to deliver a new Professor of Mental Health Nursing focusing on family-centred interventions through some instances in the book, I think, where the family becomes the unit of intervention. So, just to say, Stuart, I think one of the interesting things is to think about, we're sort of agnostic about this, what is the intervention? The question is, does it work? And there are issues about scalability and affordability and access. But do you want to comment further, Seb, I think about the peer working and things that are really interesting?
Just briefly, there was a implementation strategy to the last plan, which had some targets. There are only a few of them, but one of them, I think, outlines the scale of the ambition to change the interventions. And the assessment that was made, or the target that was made, was that consumer carer peer workers should represent 1% of the total mental health workforce within a few years. 1%. So Personal Helpers and Mentors is a program that's available in Australia, and I think when that program is full, there'll be about 1,300 FAMS workers. In the UK, for a place that's 3 times as large, there are about 30,000 support time recovery workers, STAR workers. So I said before, there are different ways of doing things and different ways of organising a response. These are often peers that are able to draw on the lived experience and provide an enduring and many would say therapeutic relationship. And so again, I'm very agnostic about how that is provided, and I'm certainly not wedded. In fact, I don't think we really can be wedded to a capital H, capital P health professional response, simply because there is not the human resources capital to draw on. We need to be thinking about things in novel ways.
How might your organisations, particularly at the national level, translate from the political, which you've stated has been somewhat achieved, to the social?
It's a really important set of questions. Seb's talked about, you might call, classical accountability, which we clearly lack at the political level. So the other level of this, from my point of view, is sort of social accountability. So for example, the Mental As program that the ABC ran the week before, I mean, that really arose out of a journalist had a good idea to write to Pat McGorry, who wrote to Mark Scott, who said, you know what, we've sort of lost the plot here at the moment with political accountability. We need a reinvigoration of the social action to let everyone know, we still need action, we still need to happen in particular ways. Another example, in the 2011 budget process, Seb was talking about GetUp, the politically active organisation, was really using new technology. They had 400,000 people sign up on mental health to say to all the politicians, and the interactions GetUp was just one part of that, but a very important part. Every time that number that was 2.2 billion looked like going south and getting smaller, and maybe the government was maybe thinking about doing something else, some key people, I'm going to say Simon Shaker, who's great credit, who was the head of GetUp at the time, would walk back in and say, you know what, we've got 400,000 people who think this is really important. Now, they were all participating simply online on the issue they chose. They weren't signing up to GetUp for Life or whatever else, to run particular things, to stay actively engaged on an issue. So I think one of the issues is thinking about how social accountability might operate in new ways to somehow continuously bridge the gap with political action. And then we haven't really fully explored, I don't think. We have traditional kind of things, but we don't you know, in the sort of mass rallies and the sort of particular things, there's a different kind of thing now of how do we have a more continuous social thing. So in that area, I'm personally very interested in how technology might interact with people in different ways. Where in the past people have signed up to political parties or they were in part of movements or whatever, in a slightly different kind of world in which we live. You know, and it's a process I'm associated with SEB through the Halfman Foundation. This issue about mental health people joining up worldwide using technologies, where they would otherwise be marginalised, to participate in communities which exist online, to run social accountability, to trade experiences, to talk about how social action might actually proceed in the communities in which they live. But I think it's an evolving thing. I think we need to find new ways of being politically active that translates also to some kind of social accountability. So it isn't just a rally of the day or a movement of the day or gets recognised in one budget. Whatever John Howard said was true. You know, these are tough, longer term, different ways of relating in the world.
Can I just say, and maybe I have the wrong end of the stick, but I think there's it's worth mentioning the notion of stigma here, which is really, I suppose, the extent to which society is ready to accept mental illness and accept people with mental illness as our brothers and sisters and as our co-workers and as us and as our bosses and so on. And I think that there's I would point to the fact that there is no national mental health promotion campaign. We talk a lot about obesity, Measure Up. There's been lots and lots of campaigns about tobacco and drugs and a whole range of other areas, but mental health is really, we haven't really dealt with it. And so there have been initiatives, and I think they've been successful because the ground is wet, because people do wish to participate. They show that through things like Get Up and so on, but it hasn't actually been organised, and I think it is essential to pose that challenge in a coordinated way. And I'm thinking again about somewhere like New Zealand, which ran a campaign called Like Minds, Like Mine, and it was not merely a handsome, well-credentialed All Black running a TV ad. That was part of it, of course. But what it also translated to was local action taken by groups that were keen to come together to talk about mental health and to talk about what they can do, not to recover from illness, but to stay well and to keep each other well. And there were tools and resources that were set up for that purpose. So again, other places, I feel, have a much more sophisticated approach and than we've been able to show so far.
My name is Christy Nancy. I identify as a consumer. I have a lived experience of mental illness and I'm a carer for 2 people with mental illness. My 2 issues that I want to raise. One is, how do we encourage a safe environment for people to disclose their mental illness? And that comes on to what you were just saying about stigma, so exciting. And so as we can share our experiences, the most important thing in my journey as a consumer has been other consumers. And the other thing that I'm worried about is with all this talk about hospitals and moving to community care, that there won't be a safe space for people to go when they need a time out from society because they are unwell, and also that I don't believe the local psychiatric services in my area are safe.
You're not the first consumer to have indicated to me that they don't feel safe in their local psychiatric service. I think that is unfortunately all too common. In terms of disclosure, there has been some work which has been done around disclosure in the workplace by people like Mental Health Australia, but I think it's really early days. And I would suggest that the stigma that I mentioned earlier is perhaps at its most difficult in the workplace. But we need to be also clear that it manifests in really practical ways, grim practical ways. For example, people's access to different types of insurance can be compromised by their disclosure. And I think this goes to what I was saying before, which is really about the overall acceptance of mental illness as a normal part of human experience and of an illness that should be appropriately addressed like other illnesses. So I think the issues you raise are real and very significant.
The safety issue, feeling safe, is so important, you know, to any kind of thing. I mean, people fear hospitals, they fear for a lot of particular reasons. So in other areas, you think about children's hospitals or whatever, go out of our way to try and change the environments and the way that people behave in those environments, you know. children's hospitals used to be much more terrifying, for example, when parents weren't allowed into children's hospitals. You know, the issue of normalising and changing the experiences, having places that are safe, but also having people behave in ways and having those shared. So again, a lot of things that SEB's associated with. The role of peer workers, the role of people with experience is actually in the hospital service I'm associated with. I think finally we're about to experiment with having people with lived experience actually meet people who are entering the acute care phase of those things. Again, in the services that Pat McGorry runs in Melbourne, one of the striking things about that a decade ago was your family member coming in is to meet another family member who's actually running their particular sets of services in those particular things, to have young people with the sets of experiences participating in the services for young people. So making them actually safe, but actually changing the way the services operate by incorporating into those things the normalisation through people with the same experiences, through family members, and of course as much as possible providing services in familiar environments, in your home, in other places, not in acute hospitals where that is possible. So there's a whole lot of thinking around that. And I think the trouble is we've had lots and lots of experiments with doing those things. So we've got a lot of insights into how to do it, but we still run in a very top-down, health-like way. Before 7, I left my office when we left. Something on my computer about why I couldn't do what I would do the bleeding obvious. Some other piece of paperwork had arrived with a new ruling as to why we couldn't do the bleeding obvious for some risk assessment point of view, for some privacy point of view, for some, essentially from my point of view, non-human way of doing things. We live in a world that has constructed more and more of those things. It's very challenging. So it's not always the fault of the individual health professionals. Some of the systems that we exist in are very sick in their kind of way of thinking. And sort of I would say the bleedingly obviously common sense of the cleaner in the hospital or the other sort of person is lost in a lot of these, at times, highly professionalised, highly legalistic type sets of services. Only your local emergency department, years ago, we talk to a person, you'd often find there's a glass wall in the way now or some other particular thing for the safety of the worker. You know, but it's created unsafe environments often for all of us. So, you know, a lot of issues where people are trying to rehumanise, which also makes safe for everyone the potential engagement. And some stuff's happened over a long period in health and occupational safety, which has really made, I would suggest, a lot of our services less safe.
I just, if I could, I just wanted to mention, I don't think that everything's great in New Zealand, by the way.
Oh, really?
No, I don't. Although, having been there twice or so, I think my vowels are slipping. But look, I did visit a service where the issues of disclosure were not an issue. It was an acute care facility, an acute care institution. It was a lovely house in the suburbs of South Auckland. It had carried wood panelling on the walls. It was run by consumers, and there was a consumer manager who managed the whole affair. There were 8 rooms. They looked like nice dormitory rooms. The whole place was nicely appointed. There were gardens to walk in, and the whole place had a feel of asylum. It had a feeling of sanctuary, which I think is what you were alluding to. The psychiatrist happened to arrive, one of the psychiatrists, and knocked on the door. And the consumer manager opened the door and said, "G'day." And the psychiatrist said, "I was wondering if Mr. Jones was free for me to see him now. And I'll go and check." And he went and checked, and he was free, and that was great. But, you know, the power of relationships, the way the whole thing worked, was completely different. So again, I just point out that I think the thing which causes Ian and I some frustration is that if there was a great deal of mystery about things, it would be sort of okay. You know, we still got so much to do to work out things, but in fact there are different types of services and different ways of working which have a solid evidence base behind them, which only occur here and here. And it used to be here, but they ran out of money, and this was defunded. And there is a wellspring of things that we know work, which are different ways of providing good care. We just don't do it. We don't scale these things up.
How do you feel that the proposed changes and actual changes to welfare provision, the dismantling of the welfare state, will impact upon youth mental illness in terms of depression, suicide, And like, how do you address those issues with the growth of the precariat, like unemployment, youth unemployment, homelessness, all those broader social issues? Do you keep data on that? And it touches upon the issue of intervention in terms of, do you present that data? Is that data that you can present in a political way to look at the social causes for mental illness?
The links between unemployment and mental illness are strong, and indeed between mental illness and unemployment. So I think the risks are there. I know people like John Mendoza have raised the issue of the potential of a growth of youth suicide as a result of changes to the welfare system. More broadly, before the changes to the welfare system, I think we really have to be, and as someone who's spent a bit of time with the National Employment and Services Association and thinking about employment support, I think there's a real case to be made that changes that were already in place and the nature of our employment support system frankly didn't necessarily work well for people with mental illness. They were often channeled into inappropriate care. The way employment support agencies were funded for their services meant that they were less likely to take on what they saw as risky clients. And again, I'm afraid this is another example where there are good examples of employment support processes which do lead to enduring employment for people with mental illness, but they are not the ones which we have in Australia. Psychiatric specialist employment service providers have largely disappeared and been amalgamated into generalist service providers. I think it's also reasonable to say that the stigma which exists to some extent in our community also exists in employment support. It also exists in Centrelink and so on. And so I guess what I'm saying, Kieran, is that the deck in some respects was already stacked against people with mental illness finding a job and keeping that job. And that's before these changes were mooted. And I think that it's something we certainly need to look at. To answer your more specific question, no. My understanding is that New South Wales is the only jurisdiction that collects the employment status of people with mental illness, and it's only for those people who are in contact with acute care. Overall in Australia, it's not a statistic we collect. In the same way we don't collect education completion rates, and again, that would be something which would indicate a trajectory towards employment. One would hope so.
Yeah, just two things briefly. The current welfare system doesn't really work, as Seb was saying. So be careful about protecting something that doesn't work. On the other hand, we are very actively involved in dumb ideas, like not providing income support to young unemployed people or people with mental illness. And this is a really big issue, big OECD issue. One of the good things about the OECD is a funny bunch of upper middle class people in Paris, one of the good. I must tell what I was saying. One of the good things about it is it points out from country to country what are dumb things to do. Right? So when a country's about to do a dumb thing, they go, we've done that. I guess you can say it's dumb because they did it and it didn't work, it made things worse. So you can say this to governments. So the debate in Australia around the proposed change, particularly around youth employment support, are being very actively debated. The mental health groups are very actively involved in commentary that if things were to go ahead as government proposes, they would have adverse outcomes. That's not simply, though, to defend how things currently are either. So I think with all these issues, there's what are the models internationally of what works better? Because the goal is for young people to participate in education, training, support, employment. So being in and doing useful stuff is good. Simply receiving welfare payments on itself and not participating on its own is not good. So it's a challenge. It's a challenge, but certainly where the government policy looks to be clearly headed towards adverse outcomes, then we're very actively involved in saying that's dumb.
We have apparently a scourge of methamphetamine at the moment, or ice. Is there anything in place that is going to deal with the widespread mental health problems that will arise from this scourge?
Just a context issue, I was saying to Joe earlier on, one of those other government things I did exist on a while ago was the Australian National Council on Drugs. And every time we went there, the main drug of abuse in Australia is alcohol, right? So the overwhelming big mental health issues, particularly for young people, are alcohol related. Funny thing to say in a pub, but there we go. For another night, Win, alcohol policy is the big drug issue in Australia. However, methamphetamine is important and it is a disaster. right? So for those who are significant methamphetamine users, often minor in combination, I think it's a major mental health issue. So actually in terms of drug policy in Australia, we do significantly better in a number of areas. So one doesn't want to, even though the media would have you believe that every single kid, you know, in Australia is suddenly a methamphetamine user, they're not. But for those who do get into those subcultures, it is a significant set of issues. So, you know, it's recognised, there are issues around it. The issues about trying to assist people rather than just policing issues are really complex sets of ones. But it's one, and interesting is where public information about harm is really interesting. So in Australia, a lot of other drug problems we've had have actually not been dealt with by policing or by regulation, but by better information to young people themselves in a particular sets of ways, and trying to influence the social networks in which those drug uses are actually taking place. So I think some of the publicity this week's been about, you know, certain rural towns where there are other sets of issues around employment, around opportunity. They're not just, this isn't just a drug problem, you know. In some inner city issues, in fact, it's the other way around. It's those with the most money who have the most problem, you know, actually. So different communities in which those things break out often are not homogeneous, and the solutions have more to do with understanding the local context of that particular drug use and providing accurate information in those particular settings.
I'm Helen. I work in an intensive youth centre close to Villa Detention Centre. So we have kids coming in and out of the centre, Villa Detention Centre. Some of them are suffering depression related to traumatic events usually, or appears to be, and also the uncertainty of their future, fears for their future safety. On the other hand, and I'm sorry to make this personal, but so that's depression related to traumatic events. On the other hand, and I'm sorry to make this personal, but my mother suffered depression during the 60s at a time when it wasn't recognised, when she was just dismissed as a silly woman, an overly emotional woman. But my two siblings suffer depression, I don't. 2 of my 6 children suffer depression, quite severe. The girl is they're in their early 20s now. My daughter is functioning well on antidepressants, but my son refuses to get any help. And I'm just wondering if you can comment on the likelihood of inheriting depression or any mental illness for that matter from parents or grandparents.
Well, just on the straight genetics issue, you know, in my family you get blue eyes, very nice. You also get a risk to diabetes and also a risk to melanoma. All families have different genetic profiles, okay? And so certain things run in families, and we know for certain mental illnesses like liability and depression, there's an increased probability. It's not that there's simply a gene or a simple factor, but the increased risk across generations is increased. And it's really important for people to know that so they can take actions and they can provide appropriate information and care. What's good is to know that. One of the worst stories in my whole clinical thing is I looked after a woman who had very severe postnatal depression. She almost died, the baby almost died, blah, 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 blah. But she only found out subsequently that her mother had actually been in Roselle Hospital for 3 years after she was born. And she didn't know that. That information was not actually shared. You know, and it kind of occurred to me at the time, God, if that was known, like it was known around breast cancer, around melanoma, she may well have had taken different actions. The whole medical system might have had taken different actions if they'd known that her mother had had such a severe illness in the face of the same particular thing. So information's power in these things, and information is about families, about that knowledge, so that people know and can share that information. Your own situation, if some member of the family responds to antidepressants and another member doesn't actually take it, you know, it's really important information to share. The Villawood one, I'm glad you raised the Villawood one, because I do have Pat McGorry trying to ring me. We debate the detention centre. I travel overseas all the time, and trying to explain Australia's attitude to the refugee kind of situation is inexplicable elsewhere in the world. Why it is the commonly accepted position amongst our major political parties to take the current set of attitudes, and then issues around children in detention, I mean, so the effects are well known. This is a classic case, I think, actually, of political action. You know, this is a political situation where we're involved in engaging in situations which do cause harm, including mental illness. There's no debate about the evidence, but to change the policy requires political action and particular sets of kind of issues. And so I think that's one where, you know, everyone just needs to remain politically active about the particular situation to somehow get ourselves out of the complete madness that we've developed nationally about attitudes to asylum seekers and things. I have been involved also in national inquiries about exactly that. So the evidence has been in favour of, you know, been presented to governments for a long period of time, but we've lost the political side of the thing. I think that is one where collectively we need to remain politically active. You know, for whatever the majority view is, it's wrong. On the other one, I think families are at the heart of sharing information about experiences, about treatments, about liabilities, just like they do. The best example in Australia is the extent to which women share information about breast cancer. We have the most fabulously organised networks in Australia of families that know that they are at risk in the actions that they take. I would hope in some future situation we would be so well organised around common mental health problems that we'd have the same sort of sets of attitudes. Knowing you're at risk, taking actions together, encouraging people to get care, both in a preventative way, but then also if they're exposed to illness, what they do to get the best possible care.
There are groups around of groups of families like the ARAFME, Association of Relatives and Friends of People with Mental Illness, if they still use that acronym as opposed to just ARAFME. Anyway, they provide a range of support and can help families work out ways to discuss things. So again, they seem to be quite proven. Families generally find them very helpful, but funding for those sorts of NGOs is token at best. So again, their capacity to actually provide those services to a broader range of people is extremely limited. And on that basis, I think that where mental illness can be confronting enough, where it's hard to find services and so on. But I'm stunned still in 21st century Australia how alone families find themselves without understanding the course of illness and without understanding how best to approach it with their loved ones. And I think that's a terrible shame.
Andrew Dickinson, I'm also a consumer and an activist. With government talking so much about research, will there be any funding left for the implementation of best practice?
Has anyone? Because the talking about research is all we're doing. We're not spending any money. Somebody may have seen an editorial by Papagori in the Australian this week. You know, the idea that we would spend money on research is an excellent one. We're not actually spending very much money on research, so the implementation is important. Actually, another colleague of Win and I's, the young Gavin Andrews, who's now in his, I think it'd be fair to say, his mid-80s, but we're not going to discuss that, remains very active. He made a very important point over a decade ago now. If we could relieve about half the burden of mental illness if we implemented what we currently know. That would leave about another half for which we need new knowledge. There's lots of stuff we don't know. So there's a lot of debate in these particular areas about the relative sets of investments that we make. So we definitely, I mean, Seb's given a string of examples this evening of things that are very well evidence-based that we do not implement. Much of it in the family and community and empowerment type areas and in different models of care. You know, that model we was talking about, that place in New Zealand in South Auckland. There's one actually in Logan, south of the river in Brisbane, that I've been to, where actually people come in acutely into a place run entirely by consumers, and if need be, they invite the mental health services to come down and help, if need be. If not, they take care of people meet every day. It's entirely, it's in a suburban home in Logan in south of the river in Brisbane. You know, we've got all sorts of models about we could invest in that are highly effective in particular ways. But that's about half. The other half, research is a really serious business. Mental health, Seb was making a comment here earlier on. These are areas you might be surprised to know that pharmaceutical industry, for example, is pulling out investment. They're going back to doing cancer and infection because it's an easy win, you know. Mental health is actually complicated. There are new treatments. We have treatments but they're not great. You know, we need substantial investments in social care and psychological approaches, but also in medical understandings of what's going on. There's a tremendous amount. There's another guy out there, actually President Obama. He's actually, the biggest thing he's investing in at the moment in the United States, the US Brain Initiative, which is actually understanding the process of the brain for use in autism, for child development, youth mental health, Alzheimer's and dementia and the ageing, because he can see it as the 21st century thing we need to understand. We're going to need to understand the mechanistic bits as well as the social bits to make it add up into terms of better forms of care. So, you know, it shouldn't be a fight between implementation and research. They should work hand in hand to do best what we can do now and then continuously aspire to do better. You think of the amount of money we spend in cancer and other areas of human endeavour for exactly those two sets of reasons. And we don't have a fight about research versus investment, we do both. That's what we've got to get to, in my view, in this area.
I attended a rally today organised by the Save Medicare Committee, which I'm a member of. I think the problem we face in Australia at the moment is that not only mental health, but the entire health system is under severe attack. And we're actually going to see a setback to mental health
and all areas of health, including the privatisation of the Medicare system, the privatisation of the public hospitals, and I would say that things like the $7 co-payment, if it goes through, is actually going to worsen the situation for people suffering mental health, because a lot of them are homeless, a lot of them are on low incomes. They're actually going to, if they're not prepared to go to a GP now, they're certainly not going to go there if there's a $7 co-payment beforehand. They've got no money to go there. I think, you know, we are really facing a huge health crisis in general in this country, organised by the Abbott government. My question is to comment on the effects on the mental health system of the overall attack that's taking place on the state and federal government on the health system in general, the public health system. Thank you.
The mental health system is in crisis, and I think that's a reasonable conclusion to make. And it's in crisis before those changes have been wrought upon the system. What I would say is that I don't think anybody would particularly call Ross Gittins a wild radical. He wrote a very good column in this week's Sydney Morning Herald, which basically debunked the whole myth about health spending being in crisis. I need to say this is a bit challenging for me, because I used to say that mental health share of the health budget was in decline, because the health budget was increasing much faster than the mental health budget. Still, the mental health system and the budget is in decline, but the overall health spending this year, I think, increased by only 1 point something or a couple of percent. It was a very small change to our overall spending. And Ross Gittins' point, that well-known radical, was it was very hard on that basis to justify the type of changes which the Abbott government was talking about, in particular the co-payment and so on. So I think I have a great deal of sympathy for the things you're saying, and the data itself is indicating also that the changes which are being suggested are not justified. I'm a bit confused about the implications of the co-payment for mental health. The last thing I read was that for mental health interactions with the GP, there would be an exemption. Now, even if that is true, unfortunately and unsurprisingly, many people with mental illness also have many physical maladies, and on that basis, the points you raise are exactly right. There would be some disincentive for people with mental illness to go and receive care for their diabetes and for their cardiovascular disease and other things. And I think that would be a very significant issue in a community where I think it is reasonable to say that the life expectancy of people with mental illness is actually around about the same as for the Aboriginal community. So you're really talking about, 10 to 15 years less life for people with mental illness. And we need to make it clear here that they are not dying of mental illness. They are dying of cardiovascular disease and other untreated illnesses. And so any disincentive for that community to go to their GP and see their general and physical health attended to is only going to compound what is already a very literally grave situation for people with mental illness.
So I don't know anyone in the serious public health community debate about things who thinks the co-payment thing makes any sense in the current debate. It doesn't make sense. It doesn't make economically, and the disincentive thing just in the youth area is particularly nasty, because we've already seen less young people come forward to some of the headspace services because they believe it's already in action. So a government announcement is not, these are people who don't actually worry whether it goes through the Senate or not or whatever. So if government says it's going to do something, they believe that they may have already incurred the cost. So we don't need any more disincentives than we already got. However, just about it's about the welfare thing. In my view, Medicare needs a serious update. Needs a serious refurb. There are a lot of issues about inequity in the current Medicare system, and Seb and I are tied up in a lot of ones about psychological services. You're 6 more times more likely to get the Medicare psychology services if you live in Eastern Sydney than if you live in rural Australia. There are out-of-pocket costs associated with that. So Medicare doesn't cover the whole cost either. Very high. There are a lot of issues about Medicare which are a little bit stuck first in the 1970s Medibank and then the 1980s Medicare, that actually seriously need to be refitted to a 21st century environment. You know, we continue to reward a whole lot of interventional specialist care at very high rates, you know, eye surgery and a whole lot of other things, and we don't take care of people as they age, we don't take care of people's mental health. So I think in the discussion about Medicare, I'd like to see the debate not be save Medicare as it is, but how do we make it work more equitably and more fairly in a complex environment in the 21st century? And that's part of the challenge, and we don't end up with sort of dumb things like the $7 co-payment as a response to what people are saying is, well, how's it going to work in the future? Because there's no doubt that the demand for medical services and the cost of medical services, quite rightly, will increase. So the equity issues will be fundamentally challenged. You know, I've got no doubt in the sense, you know, that my kids and the family I'm close to will continue to get excellent services in Australia, but that's strongly tied to my own socioeconomic status and my own geographical location, you know. And they are the really big issues, and Medicare, as it is not fixing those things. So there's some really big challenges, I think, in thinking about what are the universal issues that we're in favour of, what are the things that are advances. I am actually old enough to have existed in the period of providing medical services when there wasn't Medicare, and it was terrible. About kids who, and in Blacktown hospitals, up kids who really missed out big time. But it ain't perfect either. So I think the important debate, and it's a worldwide debate going on, is how do you construct government support for health services that deal with these equity and access issues in fair ways, but also respond to 21st century health problems in productive ways, which are a lot about chronic disease and living with illnesses and things like mental health and ageing and dementia become more important. Instead of having a system that fundamentally rewards you if you remove skin spots or you do simple operations or you do stuff, you know, that fits a simple widget idea of what's going on. Now, this may sound totally academic, but we haven't got a thing in Australia at the moment called activity-based funding for healthcare, which encourages more widget surgery and more do stuff for a unit price, rather than actually take care of people. And actually, Medicare supports it as it currently is. So some really interesting things to be thinking about, so that the fundamentals of Save Medicare, a bit like Save the ABC, I'm totally in favour of, but I think otherwise we go along and be thinking, now hang on, which bit are we trying to save? What's the principle underneath the thing we're trying to save, or further progress so that we all prosper?
Good evening, Jeff's my name. I'm a nurse. I've been working in mental health for 35 years, like my colleagues here. And having worked in that facility, that system for 35 years, I've worked through the institutions. My question basically is, are we not moving back towards institutions in a way? Because I can remember working in a facility that was on acres of land, on beautiful prime land with manicured gardens, and today we have facilities that have moved to the general hospitals, but now basically built on a shoebox. Patients don't have a view to the open land. They often have concrete walls to look at, and we can have facilities that are 100, 200 beds. Is that not an institution in itself? And my other question is, and I hear the consumers here about safety within the facilities, and we talk about drug and alcohol being the major problem. I worked in a facility where we had one ward which was 30 beds, and I could count on one hand the number of patients who come in with just a mental health issue. A lot of it was drug and alcohol, and trying to keep patients safe and staff safe when these patients are just full of anger and violence from drugs and alcohol is very difficult. What's your thoughts on separating anger, mental health and drug and alcohol?
After what was loosely called deinstitutionalisation, when most, not all by any means, but most of the psychiatric specialist hospitals were closed, many people would say that in the absence of a genuine community-based system of mental health care and support, there were in fact two institutions that took the place of the asylums. And the first one was the general wards, psychiatric wards of general public hospitals, and the second one was prison. And I have to say that, you know, again, many people, as I say, have this now as some cause to reopen the debate about how asylums offered hot shower and 3 meals a day. And people will say the same thing about prison. And, you know, I can't help but suggest that if we reach that stage to talk about the viability of that as a legitimate way of proceeding, to deal with mental illness in Australia, then we really are bankrupt.
So I think continuously the issue is, the great majority of what we're talking about doesn't require hospital care.
No.
So, really, there's lots of evidence worldwide, lots of really significant situations. You provide the appropriate support, the person's still connected with their family, in home environments or other home-like environments, you can deal with a great deal of difficulty, behavioural difficulty. But it requires a lot of skill and a lot of support and quite a lot of investment. And clearly, we haven't had that. So we've got a deficit. When you've got to use some sort of other facility, then obviously having facilities that are appropriate and appropriately staffed and appropriate is a big issue. So I think the frustration in many of these issues is we appear not to have invested significantly in any of what you might think are the 21st century kind of options. So we flip between various sorts of less than and very unsuitable sort of solutions to the ongoing problem. Mental illness isn't going away, the behavioural problems aren't going away. Seb just made the comment to me that I'd made the comment a little while ago. I can't remember the last young person I saw with a mental health problem who didn't also have an alcohol or drug problem. In fact, I haven't seen anyone in the last 10 years, a young person who did not have a significant number of those things. So the so-called comorbidity, in fact, is the commonality. So in thinking about separating those things again, there's a big issue for a lot of the people who are the consumers in the area, etc. There is a degree of violence and there is a degree of unsafety that runs with that particular, what is now the common situation. So it's not the uncommon, it is the common. And that again requires really thoughtful approaches to the particular issues. That's the reality we face. I don't think creating separate drug and alcohol, we don't attempt to create separate drug and alcohol versus mental health services is fundamentally doomed. We have to have safe environments, if I've got that problem and I was a young person, that's the set of problems that I would have. There'd be mental health and there would be drug and alcohol. That's what I would be doing. That's the environment in which we live. So instead of saying, we've got to respond in a way and say, this is the situation. What are the environments that we can deal with? Now the other side, just to go back the other way, is the earlier you intervene with one or the other, the less likely you're to end up in a situation. So we've got to change the debate. When I was very young, I'm just lying here because we and I talk about getting old. My father was quite a significant cardiologist. They used to have a debate about how many coronary care units to have, how many cardiac beds to have. In fact, for those of you who know St Vincent's Hospital, which, the wing that was built that became heart transplants was actually built for tuberculosis. By the time they built it, they'd solved the problem, and so they used it for cardiac things. You've got to be thinking about, got to change the picture, the face of illness in the future, not just build more and more things for as it is. So part of changing the picture for this comorbidity around drug and alcohol is earlier intervention with both. If you start out developing a drug and alcohol problem, you've got to intervene with young people and try and reduce those sets of problems before they have both. If you start out with a mental health problem, so we're trying to intervene with younger and younger 13, 14-year-olds before they get a major additional drug and alcohol problem, which they'll get in Australia around 16, 17, 18, if you let the problem run on. One of the challenges for us is not to be building institutions assuming that the face of what we're dealing with will be the same forever. What's been great in medicine is the face of tuberculosis. We don't have lung disease, anything like we used to have, so we stopped building the Cameron wing at St Vincent's Hospital for lung disease and made it for heart disease. We now don't have, thank God, men of our age don't drop dead with heart disease.
What do you mean our age?
All right, young men like us don't drop dead from heart disease in the same way that we did in our fathers' or grandfathers' generations. We changed the face of these things continuously. And I think one of the really big challenges here is the available evidence suggests we can't yet prevent, but we can intervene early to change the course. So we change the pattern of reliance on the sort of facilities that you've been talking about. We've still got to deal with the problems we've got today, but we've got to also be thinking about change in the future.
Well said. I just wanted to add that I think there are some very challenging issues for what has been a separation between mental health and drug and alcohol. And in particular, the recent, prominence and rise of the philosophy and principles of recovery, which have a particular meaning, and there's now a national framework for recovery, which you're probably familiar with, in mental health, that potentially doesn't fit particularly well in drug and alcohol. And so I think we have to surmount what has been service silos and also philosophical differences as we build that future and that more joined up kind of approach to what is the common experience, which is comorbidity. So there are things which are around, which have recently been built, which we need to be mindful of as we build that bridge.
I work as a school counsellor with adolescent boys and find, yes, there is a certain amount of stigma about mental health, but less so when you get to it early and you do appropriate services and you have a compassionate environment that will respond, and that's the other students. The other question I wanted to ask, was that there was a very good program, a school link program between health and education that helped to train us about mental health. That was stopped about 5 years ago. And it was a very constructive way of intervening at an earlier stage in the problems that we're talking about.
I'm aware of the School Link program, and I would suggest that falls into one of those unfortunate categories of one of those great sort of time-limited pilot type things that Australia is excellent at, where something is funded probably just for long enough to prove that it's working when the funding is removed. And so again, the issue is really about sticking with what we know and not only trialling it and piloting it, but scaling it so that it is available broadly, to every child. I'm also aware of data from other places where there has been a great deal of attention paid to the mental health of adolescents and tracking that mental health, also looking at influences, what's likely to make for stable school environments and responsive school environments, and that data is not Australian. So again, this is a critical part of what I would see as being accountability and useful tools that we could have here, but we do not. And there has not been the investment to understand. And I think that leaves us very vulnerable, and it leaves a critical sector not playing the kind of role it should be in creating protective environments for and nurturing environments for young people. I wanted to mention one other thing. In the course of some work I was doing, and I guess if I was going to be critical of Ian and I maybe this evening, we've been talking a lot about capital H health. And you're right to talk about education and indeed to talk more broadly about social impacts of mental illness and so on. And I had occasion to do some work in the New South Wales Mental Health Commission, and I think one of the big consulting firms, KPMG or somebody like that, did some work for the Department of Family and Community Services. And what they asked was, what was the extent, if you like, of the financial impact and budgetary spending on mental health clients within the Department of Family and Community Services? And the answer was $1.4 billion. And the only reason I raise that is because that figure is larger than the mental health budget in health. And so I guess what I'm saying is that you're right to pick on education, but I would say it's a great advertisement for the fact that many other government agencies have huge investments already in mental health, and they are struggling, I think, to provide proper joined-up responses. And it certainly doesn't help when proven programs like School Link are defunded.
So I'm not sure if you hear I was talking earlier. It's a great example where the policies in Australia are great, but the implementation stinks, right? If you go back in the mid-1990s, in our first National Health Plan and others, the role of schools at critical ages. So we sort of have an age plan which says, look, under 5, this is basically family business. 5 to sort of 15 is largely school business, and then after that it's largely, employment and health business. So we've actually had a national strategy that said, look, schools are fundamental from a mental health point of view, from promotion, prevention, early intervention point of view, particularly 5, and now we've got to move to a preschool kind of thing, a preschool environment, and now the school environment. And for that fact, the Commonwealth had funded mind madness programs in schools, and there have been a whole series of other school-based programs for 15 years now, in various ways of saying schools actually are the critical environments, particularly in the kind of, obviously kindergarten to sort of year 10 kind of environment in particular. And there have been, a lot of Commonwealth funded programs and then state funded programs saying, look, it's really fundamental. There's been an interesting thing in the education sector about something pushed back from schools saying, now look, we have to do everything. Now we have to do the mental health work as well. Where is the support for actually school-based programs and an interlinking of the role of teachers and school environments with the kind of additional health services? There's also and some work, particularly Helen Christensen is associated with the Black Dog Institute here. Can we use other e-health-based programs, in-app programs, to get involved in large-scale prevention programs, basically teaching cognitive behavioural programs to every teenage-aged kid? I'm associated with the thing now actually with the Uniting Church of all people, focused on primary school kids about use of after-school care, other sets of care, school-related issues. What are the supports you can provide to schools? Rather than simply saying schools have got to do it, not in your own experiences, teachers have now got to do it. What's the supportive environments around schools, since it is critical? And the critical outcome is to stay in school and flourish in school. So I think the trouble is this big gap. It's not that we're not talking about it. It's the big gap between the engagement between these critical bits at critical ages. And I think the real feedback from schools is teachers and families, they're in, but they want support to do it. You know, not just to become another thing that's in the curriculum. You know, now you'll do mental health along with everything else. My experience tonight, unfortunately, I think it's one of these things being taken up most by independent schools and better resource schools, is they've invested quite a lot. So a lot of the independent and better resource schools have quite big investments in mental health. It's not so obvious in the government schools and in other schools with lower resources, the extent to in teacher education, parent support programs, and then now programs for kids themselves, particularly in secondary schools, that there is the degree of investment that we need. And I think unfortunately it has many of the same socioeconomic kind of gradients as many of the other things that we've been discussing this evening.
As a person with a standard medical experience, I find the opaque term medical illness obscures my understanding of the real issues. Surely there are lots of special diseases, I'm using a standard medical term, which require specific attention. So I just ask you why we speak so often about mental illness and not about more specific situations.
Great comment, and I totally agree with you. It's like talking about physical health without saying what. So there's actually the stigma area. It's kind of interesting work done a decade ago. You stop talking about mental illness generally. You talk about depression, you talk about schizophrenia, you talk about post-traumatic stress disorder, you talk about... So Joe was asking us when we're going to talk about alcohol, you talk about alcohol dependence. This was actually much more helpful. Now there's kind of interesting thing that a lot of well-meaning people said, oh no, this would be bad from a stigma point of view, by giving these things specific names, and people don't want to have a specific illness. Actually, most of the people who had the illnesses said, we want a name for the illness so we can find out what the hell it is, and know what is best care for that thing. So I agree with you, although it remains controversial, because a lot of people have lived the experiences, and other people don't want to comment here,